I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, in this section, I'm going to talk about COPD. So COPD is chronic obstructive pulmonary disease. This can obviously impact breathing. It is an irreversible lung disorder caused by chronic damage. And the most common case that damage is from chronic smoking. Okay, so smoking cigarettes, we get chemicals and various other elements into our lungs, and that damages the lungs over time. Now, comparing it a little bit to asthma, it's usually not impacted by triggers. So, asthma, can kick up during allergy season, for example. COPD is usually pretty stable, like it affects patients kind of longer term and chronically, and isn't quite so reactive to something like allergy symptoms in most situations. And then it's going to be diagnosed in older patients the majority of time, compared to asthma, which can happen and begin at a very, very young age. Asthma also has that reversibility to it, where it can be pretty quickly reversed, and patients can, feel totally normal if things are going well. COPD, it's going to be chronic, and its symptoms are going to linger. Patients might feel a little bit better at times and a little worse at times, but the ultimate damage is still there. The other thing with COPD is many patients will report sputum as well. So just kind of a gunky cough sometimes, and mucus and things coming up as they're coughing and those type of things. All right, there is various staging based upon FEV measurements. Basically guides the severity of COPD. Not going to go into that too much, but obviously that measurement can help us determine where the patient falls. Another classification system as well is based upon exacerbations as well as symptoms. So these two assessments, the MMRC and the CAT, that scoring can help us determine basically what medications we're going to use. So if we've got lower scoring on these two assessments, we may just do a single bronchodilator, and that traditionally is LAMA or LABA therapy. LAMA is long-acting antimuscarinic agents. LABA is long-acting beta agonists. So I've definitely spent a lot of time on the long-acting beta agonists, explaining those a little bit in the asthma section. So I'm probably not going to do that a ton here, but I'll definitely go into long-acting muscarinic agents, or long-acting anticholinergic agents as well, or what they're frequently called. All right, so here's just a little bit more details about some of the things that go into those assessments. Again, I wouldn't commit that to memory. I just wanted that in here for background a little bit, because that does drive and help decide drug therapy based upon the severity of these assessments. So in general, we use as needed short-acting beta agonists, which I touched on in asthma. We could also use short-acting anticholinergic agents or combination. So one of the more common combinations is medication like Duoneb. So that's a nebulized medication, and that's a combination of albuterol, short-acting beta agonist, and ipratropium. Okay, so if that's not enough, if patients are still struggling, they have chronic issues with breathing, usually we go to the long-acting anticholinergic medications or long-acting antimuscarinic agents. That's where the M comes from in LAMA. Basically the same thing or very similar. Long-acting beta agonists can also be considered, so that's LABA therapy. And then inhaled corticosteroids. Inflammation doesn't play as big a role in COPD, so inhaled corticosteroids are generally not a first-line medication. And then we've got a couple other agents. I'm not going to spend a ton of time on them. I think it's important to know the big ones, long-acting anticholinergics and long-acting beta agonists. So the GOLD guidelines favor inhaled corticosteroids only when blood eosinophils are over 300 cells per microliter. So basically that's kind of a marker of inflammation a little bit. Obviously, if patients have asthma and they have breathing difficulties, we're going to use inhaled corticosteroids in that situation. If a patient has a bunch of COPD exacerbations causing hospitalizations, that's another situation where we might consider an inhaled corticosteroid. Okay, so pay attention to exacerbations, hospitalizations. We may utilize those inhaled corticosteroids a little bit more in COPD in some of those situations. And then, the guidelines, again, favor kind of a risk versus benefit discussion. So, again, not something that you're probably going to have to know as a nurse, but I wanted to give you guys a little bit of background and educate you that, inhaled corticosteroids aren't first line in COPD. They are going to be used frequently in asthma. All right, so those long-acting antimuscarinics, aka long-acting anticholinergics, or LAMA therapy in COPD, this is going to be a mainstay of chronic care management. So once patients get to a certain severity in their COPD, we are going to want to give one of these medications on a chronic basis. So how do these meds work? So they block muscarinic receptors, which ultimately leads to reduced activity of acetylcholine in respiratory smooth muscle. Hopefully you remember a little bit of this from the autonomic nervous system. This leads to that relaxation in the bronchioles, and that's going to open up that airway. Now, the added benefit is potentially drying up some of those secretions. Remember, anticholinergic medications can dry up secretions. So patients that have a lot of mucus and secretions associated with their COPD, this long-acting antimuscarinic class or anticholinergic class could definitely help dry that up. So that's kind of an added benefit compared to using LABA therapy or long-acting beta agonists. Classic examples here, tiotropium, brand name Spiriva. We've got Sebree, we've got Incruz. There's quite a few different medications in this class. Some are more dry powders, dry powder inhalers. Some are more aerosolized inhalers, so we do have some variety there. And we do have nebulization available as well. So adverse effect profile, usually pretty well tolerated. Some of the systemic anticholinergic effects, which I've gone through previously a little bit, and will in other sections as well. Dry mouth, dry eyes, urinary retention, constipation. Those systemic effects typically don't show up too much. Not that they can't, but they typically don't. If we're using it appropriately, we don't get a ton of systemic absorption. Now, the one probably exception here is, remember, we're taking these medications locally, so if secretions in sputum aren't a big problem for the patient, it could excessively dry out the mouth a little bit. So that is a common complaint that I hear from patients for sure regarding the long-acting anticholinergics. Beta agonists, I mentioned those previously. Go check the asthma section. Tachycardia, tremor, definitely adverse effects that can happen there. And then the anticholinergics, I alluded to dry mouth being common adverse effect. Inhaled corticosteroids, again, can possibly be used to help reduce exacerbations. They are not a first-line therapy. They shouldn't be used alone in COPD. In cases of severe exacerbations, hospitalizations, you may see systemic corticosteroids used. There may be, some inflammatory component there, and may help the patients feel a little bit better. So you will see them in COPD exacerbations, probably less common than asthma, but they will absolutely be used there. Just remember, acutely, systemic corticosteroids can really raise blood sugars. That's an important thing to pay attention to in our patients with diabetes. And then that dosing, keep a close eye on that. Generally recommended to give oral corticosteroids like prednisone with food because of GI upset. And then, of course, can cause some insomnia and those type of symptoms as well. Roflumilast is an oral medication. I'm not going to talk about it a ton. It does reduce exacerbations. It is fairly expensive. It can cause some GI upset and weight loss, so that's a problem. And it's also associated with psychiatric concerns. And then we do have breakdown by CYP3A4. So drug interactions can be problematic with this medication for COPD. I don't see it used a ton in my practice. Other considerations, theophylline, maybe a good drug to know just for reference sake. Historically, a lot of pharmacology professors do mention it. In practice, it has been years since I've seen somebody on theophylline. So it requires drug levels. It's a narrow therapeutic index medication. It's got drug interactions. And it almost acts a little bit like caffeine in that it ramps you up, can cause some insomnia, tremor, tachycardia, GI upset if you get too much of it or you're at toxic levels of theophylline. But it can help some patients breathe a little bit better. But again, because of the toxicities, because of the drug interactions, all those problems, theophylline is not used very often. One antibiotic in COPD that you may see utilized is azithromycin. Okay, so specifically in patients with frequent exacerbation, you may see this medication. It does have few drug interactions, particularly in relation to QTc prolongation. Not something I'm usually crazy worried about, but again, if we're using this medication kind of chronically to reduce exacerbations, we may need to worry about that a little bit more closely. All right, a few medications that I wanted to remind you of. These medications don't necessarily cause COPD. They can cause other lung toxicities. But amiodarone, an antiarrhythmic, that can cause pulmonary fibrosis. Nitrofurantoin, an antibiotic, usually in the short term, not an issue, but occasionally you'll see patients on this for urinary tract infection prophylaxis. And if patients are taking it chronically, there is a risk for some lung issues there. And then beta blockers, I've got to mention. We think about the yin and the yang, beta blockers versus beta agonists. Beta blockers can potentially blunt the response or stop the response from those beta agonists. So that could be in asthma or COPD. So important to pay attention to that. Non-selective agents like propranolol are a lot worse. But if you've got a patient that's reporting that their medication is not working very well for them, let's say their albuterol, for example, that's a good time to take a look and see if they're on a beta blocker and ask and assess the question if we think that's potentially causing some issues there. So good thing to definitely bring up to the clinician, to the pharmacy, somebody who can maybe help guide to a better selection or change in drug therapy. Some other considerations, many COPD patients, as we progress with the disease state, will need oxygen or do need oxygen. Vaccination status, very, very important. Upper respiratory infections, influenza, pneumonia, COVID. These can absolutely be deadly for a COPD patient. So doing vaccinations for those respiratory tract infections, really, really important. Smoking cessation, it always helps, even in a patient who's already been diagnosed with COPD. We can help that patient by encouraging smoking cessation. And then there is a specific deficiency in screening that can be done just to make sure that isn't causing or contributing to their COPD. So kind of a rare thing, but I did throw it on there. All right, so I wanted to point out and provide you kind of a list of some of the most common combination inhalers. So you can see we've got albuterol and ipratropium, so that's a short-acting beta agonist and a short-acting anticholinergic medication. Budesonide and formoterol, that's the combo of an inhaled corticosteroid and a long-acting beta agonist. Fluticasone, so Advair, same thing. Breo Ellipta, same thing. Dulera, same thing. Stiolto is a combination of a long-acting anticholinergic and a long-acting beta agonist, which is typically the second step in COPD management after using monotherapy. So that combination, and it's often called LAMA-LABA combination, so long-acting antimuscarinic and long-acting beta agonist. That combination is pretty common there. Then we've got Anora, same thing. Bevespi, same thing, and a few of those others there as well. We do have a couple, if you look down at the bottom of the list, we do have a couple of inhalers with 3 medications, so triple therapy. So you may see that utilized sometimes in your COPD patients as well. In my practice, I've probably seen Trelegy Ellipta most commonly, and this is really a good way to improve adherence. So if you've got a patient with 3 different inhalers, the odds that they're taking them regularly or as they're supposed to, and they're taking it correctly, that just complicates the issue, right? Whereas if we can get one combination product and it's, 1 inhalation a day or maybe 2 inhalations a day, that reduces that patient's pain and suffering and improves quality of life if we don't have to, do a bunch of different inhalers and keep track of them all. So these combination inhalers can really benefit the patient's quality of life. And ultimately, our goal is to improve their adherence as well, so we don't end up with hospitalizations and exacerbations. Acute COPD exacerbation, oxygen targets are going to be around 90%. So that's something, obviously, as a nurse, you're going to be monitoring, is those oxygen sats. Short-acting bronchodilators in the short term, acutely to help with their respiratory status. So that could be, short-acting beta agonists like albuterol, ipratropium as well, or the combination. That would be like a brand name Duoneb, for example. Short-term systemic corticosteroids can definitely be helpful in an acute COPD exacerbation. And then antibiotics and antivirals as indicated. So if patients are clearly have an infection and that's what they're diagnosed with, we want to make sure that we're using those effectively. All right, nurse monitoring, important things to pay attention to in COPD. Respiratory rate, of course. It's a breathing. It's a respiratory disease. Heart rate and blood pressure. A lot of times we're using those beta agonists, which can impact that. Those O2 sats. Usually, we try to get to the 90s in COPD or in that neighborhood. That's ideal. Some patients we can't do that, but always good to try to have a patient-specific goal there that you know of when you're monitoring them. Just paying attention to their breathing and how much they're having to work. That's an important thing to pay attention to. Temperature monitoring. Sometimes in geriatrics, we don't get a huge spike in temperature, but it's definitely a great idea to alert the provider, alert the attending care provider, like, hey, it looks like their, temp bumped up a degree here. Do you think they're having an infection? And that's what's causing the COPD exacerbation or whatever the case may be. So paying attention to that temperature can definitely be important there. And then level of consciousness, and you may see CO2 rise as well, and that can cause some sedation, cause some lethargy, and potentially exacerbate confusion and delirium, particularly in our geriatric patient population. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.